Hello, everybody. So today we're going to be talking about CRNA oversight of anesthesia assistants. The problem is rural communities are underserved in surgical and obstetric care because of poor availability of one, anesthesia services, and number two, surgical services. And while there's a high variability across healthcare systems as to which factor is the rate limiting step in patients receiving this care, uh, absent anesthesia services are a significant contributor to barriers in patients in rural healthcare systems receiving timely surgical and obstetric care. So because of this, patient care is delayed, which may adversely affect patient outcomes. So think of your appendectomies, cholecystectomies, trauma care, obstetric care with cesarean sections, ectopic pregnancies. These procedures are time-sensitive surgeries. They have a much lower morbidity and mortality when dealt with early, and morbidity and mortality increase significantly when complications develop from delayed care. So think of your sepsis with your ruptured appendicitis or cholecystitis, your unchecked hemorrhage in trauma, fetal harm from delayed C-sections, hemorrhaging from a ruptured ectopic pregnancy. Those procedures are much more difficult to do after those complications have developed. So the AANA proposes a solution to this may be CRNA oversight of AAs. Um, this increases the availability of anesthesia professionals in underserved communities, and having more anesthesia professionals in-house allows for more flexible coverage. Emergency anesthesia services better coexist with scheduled elective anesthesia services. So, for example, you may have one staff anesthesia professional in a rural access or critical access hospital, which leaves the hospital vulnerable to unplanned surgical emergencies. So you may have your sole anesthesia provider tied up in a case when a trauma patient comes in with a difficult airway, or a laboring mother comes in needing in need of a stat C-section. This lack of flexibility is not consistent with what healthcare system demands of us, or what our patients need of us. Some problems to the proposed solution. Number one is practical utility. So critical access hospitals, rural facilities, they operate with a very stringent, strict budget, and they staff one CRNA to handle the elective caseloads, but it may not be cost effective for them to employ both CRNAs and AAs at a critical access hospital that does limited elective cases, and sees limited surgical emergencies. So to counteract this, it may be beneficial to increase the elective case volume at a critical access hospital to improve this cost-benefit ratio and better justify employing more anesthesia staff. Um, so staffing more anesthesia professionals at critical access facilities would likely require more elective procedures to take place to justify this cost. This idea of decentralization would take pressure off of large academic tertiary facilities, and redistribute some of the caseload to critical access facilities. For example, the uncomplicated toe amputation wouldn't necessarily need to take place at Sanford Sioux Falls, but could rather be carried out at Sanford Vermilion with an AA administering the anesthesia and a CRNA present for medical direction. Redistributing these low acuity procedures um, with low complication rates to smaller facilities takes the pressure off of an overburdened academic center, and it would allow for the justification of staffing a more surgical and anesthesia care at smaller critical access hospitals. And this helps with the flexibility to take on an emergent case if one arises. Another potential problem would be reimbursement. So CMS does not recognize CRNA oversight of AAs as reimbursable. There would be significant legal and political hurdles to overcome this. If policy was passed that allowed for this increase in scope of practice, there would likely be very lengthy negotiation period with insurance companies to advocate for fair reimbursement for CRNAs and AAs. Logistically, the implementation of CRNA oversight of AAs would be complex. There's much to investigate before implementing this would be beneficial or feasible, but there's no doubt that increasing the CRNA scope of practice would offer the benefit of more flexibility with staffing emergencies. Um, and this would ultimately increase improve patient care and patient outcomes. The overarching theme here is that CRNAs provide high quality care that mirrors that of our physician counterparts, and CRNAs provide much more cost effective care. The downside of this is that this care is not practically available to all individuals. CRNA oversight of AAs may be a solution to this, but significant challenges need to be overcome in order for this to be an effective change in practice. Passing legislation is the first step in making policy that improves access to care for those in rural healthcare facilities. Thank you, and please reach out to me if you guys have any questions about this.